My name is Rick Robertson. I'm from Children's Hospital Boston. I first came to Children's in 1994 as a pediatric neuroradiologist. I've been in practice here continually since, and I became the Radiologist-in-Chief about a year ago. Children's Hospital Boston is one of the largest freestanding pediatric hospitals in the country. We see children from all over the world. There are several things that are unique about pediatric radiology that I think play into our desire to be able to review imaging studies that are done at outside locations. The first is that the developing child is particularly sensitive to the effects of radiation, and so we would ideally like to minimize the total amount of radiation that any child receives. This means that we would like to be able to work with outside imaging data to the extent that we can and not repeat studies that we don't absolutely have to. One of the additional things that we seek to be able to do is to provide subspecialty expertise in imaging interpretation to really be able to assist in the diagnosis of pediatric conditions. We've had difficulty over the years in managing imaging data coming in from external sources. So as I mentioned, we have a number of patients who come from different areas, and often they bring their imaging with them. Frequently, these days on a CD. Each time a patient hands you a CD, you've got to figure out what the format of the images is and how to go about viewing them in an efficient way. That's difficult for the radiologists to some degree, but we're kind of used to that. But it's especially difficult for the clinicians on the services because they're not so accustomed to having to look at different formats for image viewers. When we first started looking for options around being able to have a unified image viewer, we did look at several potential companies to work with. We chose lifeIMAGE in large part because we believed that what they were offering as product would be easier to use than some of the competition. But I think most importantly what we saw was an opportunity to be able to work with the company, and I think our experience has borne out our initial belief that the group would be easy to work with. One of the initial uses of lifeIMAGE in the institution was in our orthopedic clinic. And the orthopedic clinic is a particularly busy clinical service. What lifeIMAGE has really enabled us to be able to do is to have the patient come with their outside images to the front desk in the orthopedic clinic, hand the CD to the front desk personnel, they upload the images to lifeIMAGE, and then the patient receives their CD back immediately, has a seat in the waiting room, and by the time they're going in to see the orthopedic surgeon, the images are already uploaded into our PACS system. So the system has been extremely well received by probably our busiest clinical service in orthopedics. One of the things that intrigued us when we first started talking with lifeIMAGE was the ability to be able to upload studies from outside institutions electronically. We saw that there was potentially great advantage to this, particularly with children who might be transferred from one emergency department to another. And already within the first few weeks of implementation of lifeIMAGE, we've been able to see evidence that, in fact, this is beneficial to our patients. We've had an instance where a diagnosis was changed based on subspecialty review of the images here. We've also had an instance where the child's care was expedited because it was clear from the outside imaging study that there was a problem that required the patient to go immediately to the operating room, whereas traditionally they would have come in through our emergency department. We were able to take the child directly to the operating room, and I think probably had an improved outcome as a result. A potential long-term advantage to lifeIMAGE that we've not seen from traditional teleradiology systems that's particularly applicable to pediatrics is that for us, many sites image small numbers of patients. That means that for them to install a large-scale infrastructure is just economically not viable. What lifeIMAGE would enable us to be able to do is to go to those sites, be able to view images from that small patient population that they do image, and be able to provide pediatric care specific to those patients.